First of all, we should recognise that healthcare providers are very concerned about the welfare of their patients, especially if they're going through something as potentially traumatic and distressing as chemotherapy. But we have to bear in mind that healthcare professionals, and I say particularly doctors, but also nurses, tend to focus on what's visible and what's spoken. So when patients are actually vomiting, that's seen and it's observed, and so healthcare professionals tend to focus on things like vomiting rather than the nausea, which is rather internal, that the patients don't talk about. Sometimes they're too distressed to even talk about the nausea. Now, we know from studies that when we compare the patient's experience of chemotherapy against the healthcare professionals, and particularly doctors tend to underestimate the symptoms of chemotherapy-induced nausea and vomiting, except for the vomiting itself. They also tend to focus on the acute phase. So that's the vomiting that happens while patients are still in hospital in the first few hours and in the first 24 hours. Once the patient goes home, we know that there's a delayed phase which kicks in from day 2 up to about day 5, sometimes goes on longer. Those patients are quite invisible to the doctors, and they don't see those, and they don't appreciate the distress that chemotherapy is still having on them unless the patient comes back in. After many days with prolonged vomiting, dehydrated, we know that one of the common reasons for patients being readmitted back into hospital after a course of chemotherapy is the acute dehydration that can occur after prolonged vomiting. That's the delayed phase of vomiting, which is not visible to the doctors and nurses in the hospital. We've had international guidelines for many, many years, from the NCCN, from ASCO, from MASC, which is the Multinational Association for Supportive Care in Cancer. They all more or less agree with a few slight variations. They tend to focus very much on the latest evidence, and so they tend to focus on the newest drugs, the ones that have been through multiple trials, and therefore they tend to focus on the drugs which are perhaps more expensive. From my experience, I know that at least in the UK, hospitals find it sometimes difficult to comply with these international guidelines because they focus on the newest and the most expensive medication. That's rather short-sighted, because if we don't give the very best medication, and we know this from studies, that when hospitals do not follow international guidelines, patients have a worse experience and they're more likely to be readmitted with persistent nausea and vomiting. They're more likely to need a dose reduction in the next course of chemotherapy, and very sadly, they're very more likely to opt out of chemotherapy altogether. In other words, finish chemotherapy early because of the bad experience. Some hospitals take the view, well, let's give the standard treatment, and if the patient is still vomiting, then we'll give them the international guideline treatment. That's short-sighted, because what we know is that if the patients vomit with the very first cycle, they're much more likely to vomit next time, and they can build up what's called anticipatory nausea and vomiting, where even the sight and the feel of going to the hospital can bring on that awful feeling. For many years now, we've had an increasing range of drugs which are getting better and better at controlling and preventing chemotherapy-induced nausea and vomiting. We had, first of all, that the first generation was the 5-HT3 antagonists, like ondansetron, granisetron, palinosetron. Those are really, really important, particularly when they're combined with corticosteroids. More recently, we've had the NK1, the neurokinin 1 receptor antagonists. And first we had Aprepitant, Fosaprepitant, then Netupitant, and now we have Rolapitant. There are differences between these. We know that Aprepitant has a very short action, 1 day maximum. Netupitant slightly longer. Rolapitant has the longest action of all. It's got a half-life of 180 hours, so it goes way beyond the average 5 days that people have the acute and the delayed vomiting. Another important difference is that Rolapitant, unlike Aprepitant and Netupitant, is not affected by cytochrome P450 3A4. That's a very important cytochrome which has an impact on certain drugs that we use in cancer patients, including corticosteroids, which are very important. Rolapitant is not affected by 3A4, but it is affected by cytochrome P452D6. Now there are some drugs which are important for that, but they're actually less critical than the ones which are affected by Aprepitant and Netupitant. There have been 4 major randomized trials comparing Rolapitant in combination with other drugs against standard treatment. The first one was a dose ranging study. Subsequently, they used the standard dose of 180 milligrams. We know from these studies that in every respect Rolapitant was superior to the standard treatment, sometimes by a margin of 10 or 20% greater success rate compared to standard treatment. The adverse effects of Rolapitant are in keeping with those you'd expect from other NK1 antagonists.